Thank you so much, dear Hershey, and a very good evening to everyone again. So, we saw such impressive surgeries just now, but most of the time, because we are doing trabeculectomy and we get to see so many failing blebs, so let's see how to manage. Will start this presentation with a case of mine who presented recently to us. And I'm pretty sure that many of us are seeing such kind of patients. So this was a lady, 42-year-old, who walks with the help of two people with complaint that there is sudden diminution of vision in both the eyes recently. So when we saw the medication, she had all sorts of anti-glaucoma medication, topical and oral, and there was no systemic illness. When examination, we found that both the eyes were PL positive and PR inaccurate. Pressures in right eye were 46 and left eye was 51 millimeters of mercury. And this was the picture in right eye. We can see corneal edema, mid-dilated pupils, circumciliary congestion, and the other eye, it was even worse. So with this picture, when anterior chamber is so shallow, we can see the slit of iris touching the cornea. So the diagnosis of angle closure glaucoma was made and management was started with mannitol medication. Glycerol was added as she was non-diabetic along with rho kinase inhibitor. On third day, the vision started improving, cornea started improving, and we can see that the clarity has improved and pressure also came down for both the eyes. And on seventh day, it was furthermore better, and we can see the picture over there. There was a significant amount of cataract, but the other eye still had some persistent corneal edema. So the question is, what next? Of course, we have to do gonioscopy in such patients. And on gonioscopy, we can see the right eye of the patient, there was peripheral anterior synechiae, and it was not opening up on manipulation. And similarly, the other eye, there was total the 360-degree peripheral anterior synechiae, which was not opening up. And when we saw the fundus, it was almost near total cup with significant amount of pallor and clear-cut glaucomatous cupping. So then we have to go for definitive management in such patients. So of course YAG-PI has no such role because of peripheral anterior synechiae. So a surgery has to be planned. Now only trabeculectomy was not the option because significant cataract was there, so we had to tell the patient that it is a combined surgery. But because PR was inaccurate, we explained the prognosis and the visual potential. When we sought consent from the patient, they totally denied that when we are undergoing surgery and agar vision bhi nahi aayega to why surgery. Anyways, that was patient's choice and they went away. But again, after 3 months, that lady again came in, again two people holding, not seeing, but both the eye surgery was done. And this was the right eye surgery, and we can see typical corkscrew vessel, angry looking bleb, absolutely flat, although chamber was formed, and vision was hand movement close to face, and pressures were still 36-38 millimeters of mercury. And this was other eye of the patient where this was hypotenuse eye with 4 to 6 millimeter of pressures and over-filtering bleb. So this is a scenario of failing bleb is quite common in many of our patients, especially when they are using long-term medications. And in such scenario, what can we do for the patients? Is the retrab always an option? No, we can do a gonioscopy for such patients, and if we can see a patent ostium like this, here we can see this is a patent ostium. So that means we can go for needling in these subset of patient, which is lesser invasive procedure and can give very good result. So for right eye, we planned this bleb needling for the patient, and she was explained, and we can see this localized area which was actually causing the obstruction, and then we underwent and did needling for this patient. We can take a 26 gauge needle. Now I usually do with 5-fluorouracil 0.1 ml is required. Now, if the patient is not very cooperative, you can inject subtenon xylocaine also. But if, and always once you are injecting, I inject in the bleb area and it gives very good result. And once we are injecting, after injection, it is important to press with the soft stick so that it doesn't leak over the cornea, because it is cornea toxic drug and can lead to lots of dryness. So this patient did well, and we can see a nice bleb started forming, but I had to give 3 injections. It was given 2 weeks apart, and gradually the bleb started becoming avascular, and this was at 2-month post-operative. We can see the ideal bleb which should be there. Thankfully, the pressure got also very well controlled, and vision also improved to 636 in this eye. So what is the ideal bleb? A low-lying diffuse bleb with reduced vascularity, cystic changes, IOP in lower teens and well-formed anterior chamber with tight conjunctival closure is what we all want in our patients. But subconjunctival fibrosis is very, very common, leading to signs, leading to a bleb like this, where we if have a patent ostium, we can go for needling. So this is just to revise our anatomy and pathogenesis of failure in trabeculectomy due to fibroplasia, where proliferation of fibroblast in Tenon's capsule leads to scarring, resulting into shrinkage and of the filtering bleb, and it is important to recognize the early signs of chronic bleb failure. So what are the signs? There has to be local conjunctival hyperemia with excessive vascularization followed by rise in intraocular pressure, and there is loss of microcyst and eventual flattening of bleb. Now here we can see if we do not intervene, ultimately there is failure in these subset of patients. So how to determine whether bleb needling will actually help, as we did in our patient? If we have a nice patent ostium like this, then of course we can go for needling. But if it is blocked, like here, the iris is blocking in this particular scenario also, we can see the iris is blocking the ostium. In fact, it is incomplete iridectomy. In these subset of patient, we cannot do bleb needling. Bleb needling is not going to help, so better to go for a retrabeculectomy. So how to perform? We can perform it early in immediate post-operative phase also, and late also, where I inject the drug into the bleb area and make sure that it doesn't leak. So it can be performed under slit lamp also and under operating microscope also. So this one is being performed under slit lamp. Here we can see this is localized encystment of the bleb, where you can go underneath the slit lamp. Although if you have to do extensive bleb needling, it is always better to do it under operating microscope. So this was a very nice study from UK, where they found that bleb needling, they circulated the questionnaires, and 56% of the respondents, they were doing in operation theatre, and some of the respondents, mostly 72% were doing with 5-FU, and 22% were doing with mitomycin C, and the results were good with both the drugs. So these are few of the photographs pre and post bleb needling with 5-FU. So take home message is that early recognition and signs of scarring is important. Appropriate treatment improves the success rate. Bleb needling, if planned and done perfectly, definitely leads to good results. Thank you so much for your kind attention.